I've only had 5 subungual hematomas drained, so no personal experience. Okay, next we are going to hear from Kara Applegate. She's a board-certified psychiatrist who takes all ages, and she is passionate about having families successfully navigate neurodivergence. She has spent many rotations training at the Neurobehavioral Home Clinic, and she is going to teach us about autism. Dr. Applegate. Thank you.
All right, a little bit of a change of pace. Where do we start? So I'm going to talk about autism today. It's a little bit of a hot button topic. So a little bit of a background. I chose my topic probably last October when they really asked me to come speak here. And a lot has happened in autism in the last month. So good thing I procrastinate because I came up with a little bit different parts of autism to talk about today. I think we can go to the next slide. Do I push this forward? I actually don't know how this works. This one, that one. Okay, cool, thanks. All right, so quick intro. That is actually really hard for my eyes to see. So hopefully you'll get my notes in here. Thanks, appreciate it. So I'm a child, adolescent, and adult psychiatrist. I'm board certified in general psychiatry and will be board certified in child, adolescent psychiatry as well. I did my residency and fellowship at the University of Utah, graduated in 2022. Board certified through ABPN and MBPAS, and I put MBPAS up there as a shout out. So I started my private practice, Clear Sky Psychiatry and Therapy. It's in Farmington, Utah. I started that in early 2023. And we are a group practice. So it's led by myself, but I have 7 going on 8 therapists, 2 physicians. One of those is a fabulous triple board resident, and 2 mid-levels, and we are growing and trying to provide the best quality care, but also in a private practice where we can just provide a little bit more hands-on touch for our patients. So other than being the owner of my clinic, I don't have any financial relationships, or I don't get any funding from anything that I'm going to talk about. Just something that I'm actually really passionate and did a lot of training in are neurodevelopmental disorders, specifically autism. So I wanted to start with just a quick quote. Spencer Merrick is also a triple board psychiatrist, and he wrote an op-ed for the Salt Lake Tribune. This was published in April 23rd. So very relevant to just what's going on right now. And I wanted to give a little bit more directed information about how to potentially just answer these questions if you have patients that are coming in asking about autism, because sometimes you just don't know exactly how to answer these questions between wellness community and medicine, which is wellness community. So autism, he said, autism is not a single entity with a simple cause. The scientific community widely agrees that autism arises from a complex interplay of genetic and environmental factors. The focus on finding a quick cause distracts from what actually improves lives: high quality research, appropriate medical and behavioral care, inclusive education, supportive housing, and policies that honor the dignity and potential of autistic people across the spectrum. So just a little bit of background. I wish I'd thought about putting up a slide about this. Is just right. People are like, but the prevalence of autism has increased. What leads to that? Obviously, there are a lot of factors. What I would specifically say is, first off, the way that we diagnose autism and what the criteria are have changed immensely, right? From being a disorder that we said was due to cold mother syndrome to actually knowing some genetic mutations, that lead to metabolism changes within the mitochondria that are different in people with autism. It is still very complex. We don't have specific answers in every case that we can be like, okay, let's test for this genetic disorder specifically. So what this also leads to is that we are providing a clinical diagnosis, but talking about the prevalence as if we have something like Fragile X syndrome, right? So there just leads to this very misunderstanding of what these prevalence even might mean and why that it's increasing. So first off, I just talk about the difference in the diagnostic criteria over the many, many years since 1950, and then specifically the changes in 2013 when the DSM-5 was released, and we created autism spectrum disorder and lumped in 4 other diagnoses into autism spectrum disorder, including Asperger's syndrome. So now we are including all of the high functioning autism into autism spectrum disorder. Of course, this will change prevalence. Along with that, I also talk about, again, this is a clinical diagnosis. And if you've ever watched an ADOS being done, which is what we send for neuropsych testing, they do an ADOS, which is our gold standard in diagnosing autism. It is still very clinical and opinionated as far as what we're diagnosing. And so it does create this picture that's maybe not perfect, right? We're in the gray zone. I live in the gray zone every day in psychiatry. I cannot look at a finger and know if it is broken or not. I cannot always just look at a person and know if it is autism or not. Sorry, I can look at a finger and know if it's broken or not. And then I send them to Dr. Richards because I have no idea what else to do. But with autism, again, it's very clinical. I also diagnose autism in my office, right? I am capable of diagnosing autism. I hope you guys are also can learn and be capable of diagnosing autism as well. But it's a clinical criteria. And the other issue that arises is resources, right? So we know that certain types of behavioral resources are incredibly helpful for autistic individuals to grow and develop alongside their peers as best as possible. And one of those is obviously ABA therapy. Well, at least in the state of Utah, ABA therapy is gated by having an ADOS done. That changed a little bit in COVID, but still a lot of insurances are like, nope, you have to have an ADOS, you have to have this diagnosis of autism to get ABA therapy. So ABA therapy, or applied behavioral analysis, is actually incredibly helpful for not only autism, but other behavioral challenges, right? So and if insurance won't pay for ABA therapy, it's incredibly expensive. If you're going to put your child through 10 to 30 hours of therapy, intensive therapy per week, incredibly expensive. So what do people end up getting? They end up getting a diagnosis of autism. Again, maybe if it's correct or not, if it's accurate or not, so that gate to ABA therapy is released and then their insurance will pay for it. What does that do to our prevalence rates? Well, it also increases prevalence, right? Again, so this is just messy. If we don't have a specific chromosome to look at, this is Fragile X, but we're also looking at a neurodevelopmental disorder, it's going to be messy. So that's just a little bit of background, some way that you can kind of talk about these prevalence rates. So I want to talk about a little bit more about just funding behind autism. This is a graph that was published by Statistica back a year ago. So these are actually estimates as far as what was going to be spent in 2025. And I couldn't find an accurate exact estimate of what is being spent or going to be spent in 2025. However, the amount of money that we are spending on autism is increasing, or autism research specifically, which is awesome, right? And this is leading to more and more information and understanding about autism. I don't know if I actually can see all of my notes. Can I, is there okay, perfect, thanks. All right. Oh, I'm gonna skip that. Okay, so we'll go into, there's obviously a few different places that you can look for autism rates and just statistics. The Interagency Autism Coordinating Committee is one of the best websites out there for data. And they still have a lot of data regarding funding for autism, the breakdown of what projects the funding was spent on. They also publish a strategic plan for autism research to ensure that all areas of growth are accounted for, and looking at the research in all of these areas. They've added areas to this in the past as well. And then the Autism Cares Act that was originally signed by President Trump in 2019. The funding was increased to $2 billion spread out over 4 years when it was signed by President Biden in December of 2024. And then they're actually convening like right now to think about nominating certain papers for their strategic plan and what they put out every couple years. This is 2019 and 2020. Two most recent years that I really could find the reporting of the actual funding of autism research. And it's consistently about 80% of funding does come from federal sources, and then the other 20% comes from private funding that makes up everything else. And that's been pretty consistent over the last decade. So this just breaks down the 7 areas needing advancement related to autism. And these are put out into the strategic plan. So as you can see, screening and diagnosis, biology, genetic and environmental factors, intervention, services and supports, lifespan, and infrastructure and prevalence. So then the IACC goes through different publications and nominates them to their summary of advances every year. So I chose out just a couple publications just to show you some idea of where the research is going. Just again, there's tons on here, so that's why I wanted to leave those links, because the 20 papers that they pull out every year are amazing. It's just really, really helpful to see where we are in autism research. So an easy place to go just to see the biggest papers that were published. This broad transcriptomic dysregulation occurs across the cerebral cortex and autism spectrum disorder. This paper was included in the 2022 report and addresses the questions of biology. And there was actually RNA sequencing analysis in 11 different cortical brain areas from 112 postmortem samples from individuals with autism and neurotypical controls. And the greatest differences were found in the primary visual cortex, but these changes were found in cell type specific gene expressions, particularly affecting excitatory neurons and glia. So again, looking at really specific genetic and biological changes in autism brains. This is also an interesting study from where I sit, so it's really helpful just to kind of see what are the changes behaviorally in autistic individuals, even across the lifespan. This study compared both the level and growth of anxiety, depressed, behavioral, and attention problems in autistic cohort compared to a typically developing cohort. And then although autistic children showed elevated levels of mental health problems, it was substantially reduced after adjusting for IQ and sex differences. But anxious, depressed growth patterns were more elevated in preschool ages, and the attention problems were later in childhood ages, at least from this picture in this paper. So I really wanted to spend most of the time talking about kind of a case report and maybe some clinical pearls about what you can expect or do with a young child with autism that comes into your clinic, or if you're diagnosing autism. Again, there's a really helpful link. I'll add that to my slides as just far as like diagnostic criteria, going over the DSM-5. Again, it is a clinical diagnosis. It is helpful to know the different areas of development that you're looking at, and then also to not utilize one behavior to cross over all of those different areas. So if I see like one repetitive behavior, I'm not going to use that in multiple categories to say that they have autism. I'm actually going to be able to make sure that I can create a larger, more clear picture of autism using multiple different types of how are they interacting socially, how are they doing these repetitive behaviors, when do they do them, does it cross the spectrum, did it start in early childhood, what are their deficits in communication, and all of those things. Along those lines, research and is also being updated as far as autism in females, which can look different than autism in males. And because we've started to include those different criteria, prevalence rates have also gone up. So, case report of a 5-year-old male that was in my clinic. I still see him. He was diagnosed with level 2 autism and ADHD and a prior neuropsych evaluation prior to coming into my office. So I would say like half the kids that I see have been diagnosed with autism from neuropsych testing, and the other half have not. And so there's a wide span of parents who may know what to do when they're seeing developmental abnormalities in their child and getting some testing. And then there's a lot of people just need other guidance, and we guide them through that process. This kiddo presented early in March of 2023 at 4 years old with these diagnoses, but no other resources. So he just wasn't necessarily doing anything as far as getting him the resources that he need, ABA therapy, a specialized preschool. So we really started on figuring all of that part out, getting him started in ABA by September of 2024, and then he did start a preschool in February of 2024. I think he started, timeline's a little, I think he started in September of 2023 of ABA therapy, and then started preschool. And he is in a specialized preschool classroom. He does need a fair amount of support, and so that's why he's in a level 2 autism. So if you're thinking about the least amount of support, it would be level 1, a middle ground amount of support, it's level 2, and a maximum amount of support would be level 3. After starting preschool, he had a definite increase in his aggressive behaviors and emotional outbursts, but mom noticed that she calmed down pretty quickly, and so they just planned to continue with ABA therapy. We didn't necessarily do anything different and monitor any changes that he had. In November in 2024, teachers started getting frustrated with his behaviors in the classroom, hyperactivity, attention span, about 1 minute per parents. Parents managing at home very really well with lots of preferred activities and minimizing transitions. And then parents not necessarily willing to consider other anxiety, a diagnosis of anxiety, or starting in medications at that point. So we always kind of talk about what are the comorbidities in autism. So autism and a comorbidity of ADHD is very common. Just FYI, in the world of psychiatry, that like hyperactivity within autism, some psychiatrists feel like it is not necessarily a separate diagnosis of ADHD, but a potential just symptom of autism. Again, we're living in the gray. And then anxiety is also a very common comorbidity in autism as well. And then really common to see that as this kiddo starts preschool and is in lots of different transitions, lots of a different environment, different teachers, different children with other behavioral needs, and at home with parents who are, he's a single only child, and they apply a lot of different accommodations to make sure that he feels comfortable. So at that point, they were okay with starting some guanfacine, which I do fairly often just for some hyperactivity, help a kid, again, decrease some potential aggressive behaviors and just be a little bit more behaviorally appropriate within a classroom. And so we started guanfacine 1 milligram, extended release 1 milligram night, and he tolerated that pretty well. There was some improvement in his behaviors. However, in February 2025, again, that hyperactivity had improved somewhat. He was able to sit a little longer. Talking to parents a lot about like what's the expectation of a 4 or 5-year-old of sitting, even in a neurotypical child, of sitting and paying attention, right? So an adult attention span is pretty typical to be about 20 minutes, maybe 30 minutes. So if you're looking for a kid that's 5 years old, like, oh, we're feeling pretty good if we get 5 minutes. Their brain will naturally take a break and come back. Sometimes that looks faster, right? Again, neurotypical children can generally take that break and come right back to an activity and focus. Someone with ADHD is going to take a little longer to transition away from that and then get their focus back. But I also try to like talk to them about those expectations. So although he was sitting a little longer, a little less hyperactive, he was still having these aggressive outbursts. They were getting worse, but mostly happening at school. Not a lot at home, again, because of a lot of parental accommodation. So after a long talk with parents about what anxiety can look like in a child who has some limited communication. He does speak, but has some limited communication, especially about obviously what he's feeling and what he's experiencing. What that can look like in an autistic individual at this age is big outbursts, especially. So it's kind of either split. And this is the hard part. They're like, well, it doesn't happen at school and at home. Very common for kids with anxiety to either have outbursts at school or at home. So he was really uncomfortable in this school environment, again, with the transition into school, whatever's happening at school, and then the transition home. Whereas a lot of other kids, you'll see that they are perfect at school. There are no issues, and then they get home and they're having constant meltdowns. Again, they're trying their best to keep it together for everyone else around them, and in the evenings, that just becomes a lot harder. So we actually plan to start sertraline at 12.5 milligrams nightly. That might seem incredibly low. I wanted to point out that very often in autistic individuals, they will respond to incredibly low doses and be very sensitive to medications, especially SSRIs, and so I am very gentle. So 12.5 milligrams nightly. Lo and behold, he comes back about 8 weeks later, and he is doing substantially better, to the point that he is addressing me and talking to me a lot more within the office. Just visibly feels calmer and more peaceful, and is able to just maintain that tension actually even better. So this is the hard part too, is that those comorbidities of anxiety can also get in the way of looking like ADHD, that they can't focus, that they're feeling like hyperactive and agitated, right? That can all actually be really wrapped up in anxiety. Again, because of all of the other voices that we have in our community, there, for some reason, it's easier to maybe think about your child having ADHD versus anxiety. But if you can get the parents to come around to it, treat the anxiety first. See if you can see that anxiety and treat it before treating the ADHD. You might get really far and not have to treat the ADHD at all. So our plan right now is just to continue on the 12.5 milligrams of sertraline. Eventually, I'll try to stop the guanfacine and see if he's doing just the same. I do make one change at a time. So again, if a kiddo is doing better, where shortly after, it's only been in 8 weeks, I'm not going to change anything until I've seen that stability for about 3 months, and then I might change one thing. So changing one thing at a time definitely gives us a better picture as best as we can. So just really quickly, there's 2 different antipsychotics that are FDA approved for autism, and mostly the irritability, aggressive behaviors, agitation in autism, and that's risperidone, as well as Abilify. And then other off-label or investigational treatments. SSRIs are still off-label. Obviously, we're using them for anxiety or depression. They can still be extremely helpful. So again, look for that anxiety, look for the depression, even in autism. Stimulants, again, can help with the ADHD or the hyperactivity piece. We also are using a lot of NAC for just the repetitive or potentially self-injurious behaviors. So N-acetylcysteine, I use that all the time in my clinic, as far as, again, even in patients without autism, skin picking, also always start with NAC. Melatonin, often used as well. And then oxytocin has some investigational treatment aimed at really improving that social emotional reciprocity. Not ready for prime time. So these are other resources that you can point your patients to. Autism Speaks is a fabulous website. And then Spark, which is also a ongoing collective research of getting samples. They have over 50,000 families, and they're just gathering data. So a really great place to also send in patients with autism so that we can gather as much research as possible and look into the potential other genetic things that we have missed, right? Again, it's still very new. We don't know everything. We do know it is a genetic neurodevelopmental disorder. And that is where I am. So can take any quick questions, but I also want to get us back on time.
Well, thank you. That was marvelous. We will take questions, but since I have the microphone, I get to ask the first one. So since we will know the cause of autism by September, how has this political environment affected your practice?
Other than me just up at night researching, thinking, right, it's hard. But specifically, I think it just really opens the dialogue. So although I get fired up and a lot of my colleagues get fired up, it really does, again, present that opportunity for another open dialogue where patients are actually coming and asking questions. And we know the research out there. We can point them to the right resources to give them the right information. And more than ever right now, like that is our job as physicians, not only in autism, right, but in every area.
Great presentation. Thank you for the efforts to help us better understand autism. The challenge that I have as a primary care physician with making the diagnosis is because they'll carry it for the rest of their lives. Mm-hmm. And though I see the gambit of health conditions in my office, I'm really hesitant to give a child that label. The challenge that I have with getting the correct diagnosis is knowing where to go. There's a few neuropsychologists that I'll use in the area, but I don't know if you could list resources that could be used, especially those that could be affordable to folks at a lower socioeconomic background, because it's nice to have a case where you've got a single child and two parents that are very involved, but that's not always the case for this condition.
Absolutely. I should have put that on there, but utah.medicaid.gov does have a whole list of businesses within Utah that will do ADOS testing. So you can actually find that on there, and they update it every year. I usually print that off. That is a resource that I provide to parents in my clinic when they come. I'm like, here's the list. My only beef with the list and thinking about testing is if you're like, oh, I'm pretty sure this is autism, feel pretty good, confident about that, then I will generally be fine with them going to an ABA service that does ADOS testing. Right, so there's a myriad of ABA therapy services in Utah, and they often do their own ADOS testing. However, they're usually just doing an ADOS and not a full battery of neuropsych testing. So if I am like, yes, this is slam dunk, we just need that diagnosis to, again, decrease that barrier to actually getting ABA, I will send them to any ABA service that does that. It's often faster and sometimes covered by insurance. Within that list on utah.medicaid.gov, they actually list in the last column all the insurances that particular company takes, and some of those are Medicaid. If you're thinking like this is really on the fence, then I do generally send them for a full neuropsych battery, and that's something, I'll refer to the University of Utah law or HMHI. Correct me if I'm wrong. I don't have a lot of great contacts within Intermountain that actually are doing neuropsych testing, so it's more out in the community, Neurobehavioral Center for Growth, and then there's a few up in northern Utah County, or northern Davis County.
Thank you very much. I have one question and perhaps a related second question. First question is, with children with spectrum disorder, which seems to be the more popular term to use currently, as they age, as they become teenagers, and then as they age into adulthood, what happens with them? Now, many of us have seen the Rain Man movie, and so that's an adult, and we've seen that situation, but in general, what happens as these children age into teenage and adult years?
Again, it's just a really question of resources and what their level of support is needed, right? Most people with autism spectrum disorder go on to live a full and healthy and happy life, working jobs, having spouses. You would never necessarily know, I guess, if that's the way to put it, versus having and needing more resources. And so some of these individuals may end up in group homes as adults if they need a lot more substantial support.
The second part has to do with parents. I have an association with a family, and the child is 12 and is a very high-functioning spectrum disorder child, and his mother is a single mother. I'm wondering about who herself has what I conclude as not the usual kind of behaviors in communication and relationships. What do you have to say about the parents of these children? Is there, we would like to think that, oh, there must be a genetic relationship in this disorder. Do you have anything to add about that?
So asking more about like the biology of it or versus like the resources for parents?
Well, no, just the behavior
The
of
behavior.
parents.
Yeah.
If parents often have sort of autistic, particularly communication differences, it's kind of hard to tell now because this is a relatively young parent, 39, and at that age and a little younger, it looks like many of us, rather than speaking to each other, we have to go through our iPhone, and we have to not be really communicative, but we have to seem to text so that there's not really a personal connection.
Yeah, I mean, we've seen that, right, in all teenagers, of just learning these communication patterns. Again, the nature versus nurture of it. I think it points back to even having ABA therapy, why we know that that's so successful if we've started at really early ages, can make a huge difference in that social emotional reciprocity, in those communication patterns, and learning that, right, they're capable of learning. So are all teenagers, but it's taking away those accommodations and allowing them to have the experiences to learn the communication. And obviously these things are patterned at home, so a large part of my job is to help parents as well. Maybe they're not seeing their own deficits. They can also be in therapy. Again, ABA can be done at home or in the center, and there's different polls for different reasons. If there's more struggles at home, potentially between a parent and child relationship or what's going on there, then ABA in the home is incredibly helpful. If the child is really struggling to adapt with peers and speak with peers, then those in the center groups are also incredibly helpful.
Last question.
N-acetylcysteine is used in a variety of different things, but I seldom find that it's FDA approved for those uses. In the uses you're using it for, is it FDA approved?
No.
And what doses do you like to use?
Very good. Yeah. So I generally start with 600 milligrams twice daily, and then it can increase all the way up to like 3 grams. Generally, I'll find like that some improvement between 1,200 milligrams a day and 2,400 milligrams a day. The hardest part with this that I found is they're generally very large tablets, and small kids can't swallow them.
Even on a small child, you're starting at 600? Okay.
Thank you, Dr. Applegate. So